My name is Daniel Rodriguez. I am an electrophysiologist and I work in a university hospital 12 de Octubre in Madrid. We treat around 300 patients with atrial fibrillation per year. We do different types of ablations, but mostly about 90% of the first ablation cases that we do are single shot, which are currently cryoablation and PFA. We've been using POLARx. Now we shifted to POLARx FIT in all the cases that we do with the Boston system, and we also use Arctic Front. Yes, basically it's a balloon that has the capacity to increase its size, to increase its diameter, and therefore it allows a different way of occluding or positioning the balloon against the ostium or the antrum of the vein. That comes with an increase in inner balloon pressure, which could also mean that the maneuverability of the balloon is a bit different and the way you handle it to occlude the vein could be slightly different. Yes, in our workflow we tend to start always with the 31 millimeter size. There's no data so far on the potential benefits of it, but we assume that by treating a larger area of myocardial tissue, of atrial myocardium, we may be more effective in long-term outcomes, freedom from atrial fibrillation, and also, particularly in the right superior pulmonary vein, we may be safer and we may have less phrenic nerve injury because by being more antral, we would be shifting a bit further away from the anatomical position of the phrenic nerve. If by in that size, in 31 millimeter size, we don't achieve complete occlusion, grade 4 occlusion, then we try with the 28 millimeter one. It has changed in that way, that we now have a more versatile tool that allows us to do more things than just one fixed size and different ways to try to maneuver the system in order to occlude the vein. But it hasn't changed much in terms of what we have to do in the preparation of the patient and in the time that we use, both fluoroscopy time and total procedure time, or in the way we sedate the patients. The rest is pretty much the same. That is a very good question. Always, and we still do that, when we have a large common ostium, if we don't occlude at the ostium or at the antrum of the vein, we do applications both to the left and to the superior and inferior branches. So we still do that if we don't achieve complete occlusion with a 31 millimeter size. It has, we don't have the feeling that when we have very large common ostium, this is still the case. We have had some cases in which we tried and we didn't achieve complete occlusion with the 28 millimeter size, and we did achieve occlusion with the 31 millimeter size. So there are these veins that are on the threshold. And then in terms of dosing, I've always, in our protocol, we use 240-second applications in any case. We still do that. And when we have, and that is different, that is singular about this balloon, when we have a vein that, despite complete occlusion, isolates it quite late in the application, despite good occlusion, despite good temperatures, the only option that we had before was to prolong the application. The option that we had with the Arctic Front was to prolong the application, assuming that there may be more epicardial or deeper connections or broader connections in that vein, and that's why it took longer to isolate. Now, what we do in these cases is that we do 31 and 28 millimeter applications in that vein in order to try to achieve a more durable isolation. We don't have data on whether this will be more effective, but it's an additional possibility that this balloon offers, and we're doing that. Yes. I think that trial has showed, well, the first thing that we all expected to see was that the balloon is equally effective and at least equally safe as the 28 millimeter fixed size balloon, which is good. That was like the basic that we needed to see. And then we have all the things that, again, we expected and we have seen in that trial, which is first that we can increase the percentage of veins in which we achieve complete occlusion, and that is important, not to have any leaks, any gaps that can lead to future gaps. And the second one is, as we were mentioning before, that we are capable of treating a broader area of tissue, and we assume that this may eliminate part of the tissue that is involved in sustaining atrial fibrillation, especially in persistent cases in the long run for the patient. So I think those are both good data that this trial has shown. So. I think it's a good catheter. I think the isolation, the individual isolation of each of the electrodes does yield a better signal quality. And in the case of the POLARx FIT, when we are using the 31 millimeter size, the fact that we are doing the applications more antrally does shift the position of the polar map a bit closer to the ostium. And therefore we increase the likelihood, the chances of having signals, and therefore seeing time to isolations. For a few years we didn't see many advances in cryoablation technology. It was a system that was working quite well, and so probably it wasn't very easy to produce significant improvements to it. But we have seen some now with the advent of the POLARx and the POLARx FIT system. Certainly having a variable diameter balloon is one of them. Then there are other minor issues, or issues that could be considered minor throughout the procedure, but that are made easier by the system. Specifically regarding the console, I think having the possibility of actioning different aspects of the procedure with the pedal or with a remote control is useful, especially if you don't have a lot of people around you in the EP lab, and you wouldn't need a lot of people around you, so it's good to have. And visualization and the recording of different time points, time to isolation, freezing time to -40, thaw time, all that is quite nice to have automatically. And with regards to handling of the system, it's a bit different to what we were used to with the Medtronic system, but it's adapting to it. It's very easy, I would say.